call the first presenter. But before then, we just finished lunch, and many of us will be dozing. So I crave your indulgence to try and stay awake so that we can listen attentively and make contributions to the presentations so that we can make them better. Thank you very much. So the first presentation will be...
Right. So the first presentation, the title is Self-Reported Emotional Well-Being of Ghanaian Healthcare Workers During the COVID-19 Pandemic. Evidence from a nationwide survey. And this presentation is by Dr. Joseph Boni, et al. Right, Dr. Boni, so all the best. How many minutes are we giving? Okay, just 10 minutes for the presentation.
Hello, thank you very much, Chairman, for the opportunity. So we are presenting on the self-reported emotional well-being of Ghanaian health workers during the COVID-19 pandemic. Evidence from a nationwide survey that was conducted during the first wave of the COVID-19. My co-authors and their institutions are shown up here. So the frontline workers during the COVID-19 are at the highest risk of infections and a lot of stresses. We know what happens in the hospital where agitated relatives, very sick patients, and it puts on a lot of emotional toll on health workers. So there has been some work done by Ufori et al., which focused on the 3 health facilities in Ashanti region, and also work by Edujidu et al., which focused on the emotional well-being on just radiologists. Radiographers, sorry. We noticed that these papers were in silos. We didn't have a paper that had a broad view of all the health workers in the country. So that's we went ahead with the emotional well-being of diverse health care workers population during the first wave of the COVID-19 pandemic. This was part of a bigger health worker survey program that we did, which had WHO approved survey program, which Ghana contributed in its development. But we quickly adapted this program to fit the context of our country and rolled it out through a red cap survey. In order to make this beneficial and attractive, we added a CPD accreditation course that will be free for you when you completed the survey. So it encouraged a couple more people to complete the survey. So it was a cross-sectional online survey, and it was online. We disseminated it across the country through the regulatory authorities and the professional groups. And we aimed at healthcare professionals who gave direct care to patients, not direct COVID-19 care, but direct care, since we weren't sure who had COVID-19 or not. As I mentioned before, it was a red cap survey. And at the beginning, we had 4,739 respondents, but after data cleaning, we had 4,412, and went through the analysis using R, and this was approved by the Ghana Health Service Ethics Review Committee. So a simple table showing some of our figures. We realized that there wasn't a big difference between the males and females. There were more males than females, as opposed to what the population census tells us in this case. But we realized that we had 51% of the people were either married or living with people, which as we go on the line, you realize where the importance for this is. And about 72% of them had a first degree. So this chart shows the percentages of the categories of health workers we had. In the natural scheme of things, we expected a higher percentage from the nurses, but this wasn't necessarily the case. We had more doctors answering the surveys, followed by allied health professionals, who are a huge group of very diverse disciplines, physician assistants, pharmacists, and then our nurses also. So we can see the percentages up here. When we asked about health workers' contacts to COVID-19, so the question was whether you had personally cared for someone with COVID-19. We had over 2,500 of them saying that yes, they had cared for a COVID-19 patient. By a higher number, 3,682 reckoned that their facility was taking care of COVID-19 patients, but weren't sure whether they had had contact with them. When we asked the same participants whether they had had any prior experience in managing acute respiratory disease, we realized that a higher number of them, almost 3,000 of them, so 2,895, mentioned that they had not had any such contact before. So COVID-19 was the first acute respiratory disease that they were managing, and they were managing in a pandemic setting. We went ahead to ask about the confidence in the proper use of the PPEs. We realized that our nurses said that, so between agree, strongly agree and agree, we had quite a higher proportion from nurses and our health assistants saying that they were quite comfortable with the proper use of PPEs. Surprisingly, we only had the doctors, those who were sure, were only about 40%. But we also noticed that our nurse assistants had a smaller percentage, meaning that the training had probably been centered around the higher level of staff and hadn't gone to all levels of staff, probably because they were not expected to manage such cases. We went ahead to ask whether they thought that getting COVID-19 was within their control. And surprisingly, a higher number were actually convinced that if they will get COVID-19, it's through an action of theirs. So they had control over getting the disease. And also almost all admitted that getting the infection or the risk of the infection was part of their job description, which was quite surprising as opposed to the public outcry for the health workers that they had not signed up for COVID-19. And we went ahead to ask whether they were concerned in getting ill. And funny enough, there was a slight decrease within the people that were concerned in getting ill, but there was a more bigger concern in the risks to their family members. So we realized that earlier on I mentioned that 51% of our participants were either married or living with somebody, and their concern was the risk of transferring the COVID from the hospital to their family members. And when we asked whether they were afraid of caring for COVID-19 cases, we can realize from the graph here that it was all over the place. Some people were afraid, some people were not afraid. And I think a detailed qualitative look into this will tell where the fear elements are and why people were afraid. But that doesn't fall in the scope of the study. So we went ahead to ask, so these are some of the estimates of some of the conditions, the things I had mentioned already. Approximately 79% accepted that the risk of the infection was part of their job, and also 58% of them agree that they were in control of whether they will be infected or not. Then we went ahead to find out how they felt whilst they were managing COVID-19 patients. So the wellness of the health worker, almost 80% said they were still in good spirits. They maintained a healthy atmosphere in the hospital. They were calm and collected, also around 80%. And around that same number, maintained an active and vigorous attitude. So they were not dull. There were no obvious sense of a depressed attitude whilst in the hospital. Looking at the inferential statistics, we realized that the males witnessed a significant increase in their well-being relative to the females. The difference wasn't quite big, but increasing in age since the disease was more prone to give severe conditions to the elderly, but they seemed more calm whilst in the hospital. Using the allied health professionals as a chart, we compared their wellness to the medical doctors and the nurses, and we realized that the allied health professionals were in a more well state, were more calm and collected in the health sector than the medical doctors and nurses. This can account readily from either the non-direct access to patients or so on, but this was not investigated. So in conclusion, the healthcare worker
Yeah, thank you very much. He did it in good time, well within 10 minutes. The next presentation is on seroprevalence of IgG antibodies. So what we are going to do is that we'll listen to all the presentations, you note down your questions, and then we'll have question and comments time. So the next presentation is on seroprevalence of IgG antibodies against SARS-CoV-2 before vaccination among asymptomatic teaching staff of the College of Health Sciences, KNUST. And this presentation will be by Jay Latte. He's not here. All right, then we can allow the third presentation, which is by Dr. Anthony Ewa. That's seroprevalence of COVID-19 in Kumasi. Please let's give him a round of applause.
Okay, so I kept a bottle of water here. I learned a trick when you're not sure if you're emotionally settled for the presentation. You just sip something small to just let the moment pass by. Hopefully that works. So we are here to share a bit of the work we are doing on the seroprevalence of COVID-19. And these are the authors. There's a great team that is working together to put this work together. Oh, sorry. All right. One of the things that happens when somebody is infected with COVID, regardless of they're showing symptoms or not, is the production of both IgM and IgG antibodies. And it is possible to use the IgG antibodies that are produced to predict people who have previously been infected with SARS-CoV-2 before. And so we took advantage of this to be able to develop a seroprevalence study to quantify the proportion of the population that may have been infected. Now, this was very important, especially in a resource-limited settings, because what we were getting from the testing we were doing here in Ghana was the rate of positivity. So people who feel they may have had COVID report to the hospital, samples are taken, and they test for nucleic materials for the virus. What this means is that a large majority of those who may have shown mild symptoms, no symptoms, or had not reported to the hospital would not have been tested. And so it is very difficult to estimate the burden or the prevalence of the disease. However, because IgG antibodies that are produced in response to the infection lingers on for quite some time, it is possible to use this as a surrogate to determine the prevalence of the disease in the community. Now, the aim of this study was to estimate the SARS-CoV-2 seroprevalence in Kumasi. There are other objectives that we explored, but for the purposes of this presentation, I will not go into that. Now, what we did, sorry, I'm having problems with the mouse, apologies. So what we did is that we use an app. Area, which is not a household. What we do is that we will choose the next available household, which is residential, following specific instructions. We will capture the data using RedCap on tablets, and we will take blood samples to the lab. So once we get to the lab, we separate the plasma from the blood. Then we use an ELISA method, which is validated in Ghana. It is one of the best performing on the market at the moment, produced by our collaborators from the Bernhard-Notch Institute for Tropical Medicine in Hamburg, Germany. Then we analyze the data. So I show here a team. Able to take samples from these districts in Kumasi, and in total we sampled from about 343 households. Now, we had approximately 40% of the people we sampled from getting COVID-19, and we had slightly higher seroprevalence in males as opposed to females. We also had slightly higher seroprevalence of participants who were above 50 years as compared to those between 30 and 50. Then we also noticed that seroprevalence was quite higher between those who had up to secondary and those who had only just pre-secondary education as compared to those who had at least a tertiary education. I'll show a graph So this graph shows the same results I presented in the previous slide, but it's able to show the differences. Now we don't show the inferential statistics we did here, but there were no statistically significant results when we looked at the seroprevalence stratified amongst the we created from the results, from the locations that we picked, do show that the infection or the transmission of the infection was not centralized. So from all the areas that we sampled from, we saw that there were people who had been infected prior to that. Now, seroprevalence in Kumasi, earlier said, is approximately 40%. Is a take-home message. Higher seropositivity among males compared to females. Seropositivity is lowest among people who are within 30 to 50 years, and it's about 7 percentage points lower compared to those who are above 50 years and those who are below 30 years. We see an educational level gradient for seropositivity where persons with lower educational level, none or pre-secondary, had seropositivity about 10.5 percentage points higher compared to persons with tertiary level education, which we use as a proxy for socioeconomic status. The next steps will be to sample from Accra and Tamale. We just We will finish the sampling in Accra this week, and we will move on to Tamale as well. Now, we have achieved some success through the study, and one of them will be we've been able to set up infrastructure and capacity for local serological testing for SARS-CoV-2, the provision of seroprevalence data to the Ghana Health Service, and the President's Special COVID-19 Task Force to inform the fight against COVID-19. Now, we've been able to train one MPhil student who is still under training. Hopefully, will finish next year. And we were able to support the generation of evidence to assess the performance of a locally made rapid diagnostic kit for COVID-19 testing using the ELISA as a gold standard. We've been able to transfer capacity, particularly for this ELISA we used with some of the staff and students we worked with. And we like to acknowledge the partners, collaborators, and colleagues, funders who supported this work to make this very possible. And I show here in this picture a section of the group who have been working together to get this done. I featured my boss on the left in the picture here. So thank you very much. The more appropriate time, we take questions for those who may have questions for us. Thank you.
Thank you very much. I think we've had two excellent presentations so far. Is Dr. Ade AA here? Dr. Ade. Okay, so okay. So Elizabeth Safofojo will be presenting on the last topic, which is in a world of our own, perception and psychosocial experiences of COVID-19 patients in an isolation center. Elizabeth, all the best. You have your audience.
Hello, good afternoon. So I'm presenting on the perceptions and experiences of individuals who were in isolation center, an isolation center in Ejiso. Okay, so as we all know, COVID is a new disease that was found in Wuhan, and like everything that we know about COVID. It also affects a lot of people, and it affects people psychologically. As in, when it started, there were physical affects you get sick and all of that, but they also had psychological implications for the people who were affected, the community, and almost everybody. There was fear, there was anxieties, and all of that, and there was even literature showed that there were a new kind of phobia was formed when coronavirus came in. That was coronaphobia, which is the fear of getting infected or infecting other people, and also of being in isolation centers or being stigmatized. So COVID brought with it separation from loved ones and anxiety and so many other things. And now people who were separated from their family members were sent to isolation centers. So, but for the still on the introduction, the first case of COVID was seen in March 2002 in Ghana. Government's response was to control the spread of COVID. So they initiated lockdown, contact tracing, testing, and isolation. They set up isolation centers across the country, and this was to manage the spread of it. Now, the management of people at the isolation centers had both positive and negative psychological implications for patients, but our literature search indicated very no literature, especially with the experiences of people in isolation centers. There was no literature, especially in Ghana. So we decided to go in and test, interact with them and find out their experiences, their perceptions about COVID, their experiences in the isolation centers. So that's what we are going to do. So if you look at the aims, it looks at exploring COVID patients, perceive these perceptions about the disease and being in the isolation center. We also wanted to gain an understanding of their experiences when they were initially diagnosed with COVID-19 and the psychosocial experiences they had in the centers. And also to look at experiences of stigmatization. So with this, we looked at these research questions. How did you feel when you first received the news of your diagnosis? How did you feel and react when you were informed that you would be brought to the isolation center? What were your expectations coming to the isolation center? Your experiences at the isolation center? And basically, that's what we did. And looking at the method, it's a purely qualitative study where we use the phenomenological approach. This gave us the opportunity to look at the experiences of the individuals in the isolation centers. We went to an isolation center at Egeso. Our sample size was purely 14 males who were aged between 18 and 42, and they were of different occupation. We used purposive and convenient sampling, and we used semi-structured and in-depth interviews. We conducted semi-structured, in-depth interviews using semi-structured interview guide. We used thematic analysis to analyze the data, and this included the initial reading of the transcripts. We coded, we grouped the codes into sub-themes, and then we also created themes, which we are going to discuss. If you look at, when we asked them about the diagnosis and also how they felt, its psychological implications, or how the emotions they felt when they were diagnosed, some of them mentioned that they were afraid, and then so they panicked. So if you look at some of the quotes, someone said, frankly speaking, I was devastated. It wasn't easy for me at all. I had to change the clothes I was wearing because I was sweating profusely. I really panicked. I was really scared when I was informed. Now, the reason for feeling that was that, this is what he says, that as you know, in the hostel, and then a lot of people are there. So in that case, if they were described, this is a student, and so him being receiving the diagnosis as being positive, and then the possibility of being sent to the isolation center was also one of the reasons why he was afraid and then panicked. And so he says that because he's in a hostel, there were lots of people at the hostel, and so when they are coming to get him, an ambulance will come and everybody will see him. So he was afraid of being stigmatized. There was anxiety. People also mentioned feeling anxious, and this person said, hey, when I was told, I became very anxious. And this person was also very concerned about stigma. That is also why he was anxious. Another person will experience shock when he was told that you have COVID. And this person was shocked because he didn't think that he was going to contract the disease, and also, contract the disease basically. And even though he was experiencing some symptoms, he still didn't believe that he would test positive. So he was rather thinking that it would be malaria instead of COVID. But when the diagnosis came, he was still shocked. Some people said they weren't afraid at all. So he said he wasn't bothered because he didn't feel any pain and all of that. So he was fine. That's why he wasn't, he was okay. Some also mentioned that they were calm. And this because when it comes to situation like this, I was not disturbed. Anything can happen. I thought about it for a while and I wasn't afraid. So he was calm. He wasn't bothered. he was just fine with the diagnosis of COVID. When they went to the isolation center, we also asked them about the initial, when they were told initially that you were going to be sent to the isolation center. And it appeared that most of the respondents felt anxious, scared, and were worried. And this was because of some of their perceptions that they had about the isolation centers. A lot of them felt they will be treated as prisoners. So they were very, very anxious, and it was just, they were uncertain about the whole experience, like being taken to the isolation center. So it was, the anxieties were surrounding this. Others were hopeful and still hopeful and calm because it was a place that they were going to get their cure from. So it was just fine for them. So these are some of the reasons why they experience some of these emotions. The mode of transportation. This person was very anxious about the fact that an ambulance would come and pick them. As the student also said, the ambulance would come and pick him to the isolation center, which would mean stigmatization. Also, some of them had heard information about isolation centers on the in the media. So, and the way they said, they described being in an isolation center and all of that, they felt it was, it denigrated the sickness. So they were afraid they were not going to receive, they were going to get stigmatized, they were not going to receive the best treatment as well. There was also uncertainty. Say, I don't know what is going to go on at the isolation center, so definitely I'll be worried. So if this person said, I heard a lot of stories about the isolation center, you don't go out, like you're being treated like as if you are some sort of a prisoner. I was really scared. Stigmatization, as I said too, and some said because of the work that they were doing, if patients saw them being transported to the isolation center, it meant that they will be stigmatized. Those patients won't come to them to come and receive treatment for them. So that's why they were also worried. They also experienced those experiences. But when they went to the isolation center, we looked at what they actually experienced in the isolation center. And some of them mentioned feeling very, very comfortable. And they had a very good time at the isolation center. They had their own room, their own bathroom, toilet, their own fridge. And they had a doctor coming to check on them every morning. So the food too was very good. So it was a plus for them. There was also an opportunity to socialize and bond. And they provided them with games like football, Ludo, and so many other things that they had. They played them together in groups. You find people playing groups, playing Ludo and those other things. So it was an opportunity for them, which they enjoyed. There was also freedom. They also had support and care from the staff as well. So this brought on feelings of joy, satisfaction, a sense of belonging, because they felt that because you are taking they share their experiences, they bond together, and then they share their experiences. So you didn't feel lonely when you went to the isolation center. And some people were actually sad about leaving the isolation center because they really enjoyed the food and everything. And so if you look at what they said, the initial anxieties and distress were associated with the diagnosis of COVID, were dispelled due to the experiences that they had in the isolation center. We will say that more needs to be done to alleviate psychological distress among COVID patients. And this would be to educate and create awareness about contracting the disease, provide psychological support for those who are initially diagnosed, especially at the time that their sample is taken and then the analysis, and when they are told that this is what you have. So I think that the breaking of the news to them that you are positive for COVID should be done in a way where a psychologist may be employed to help with the breaking of the news to them. And maybe they should also consider the mode of transporting the patients to the isolation centers. Thank you.
So, we've enjoyed listening to the presentations. Has Dr. Latte arrived? Seroprevalence of ICAM is still not with us. Okay. We will now invite the presenters to the days so that they will have face-to-face with the listeners for a good interaction. Please come up stage so that we have and the procedure will be that if you ask a question, the question should be snappy, straightforward, and if you have a suggestion, make it short so that the presenters can take in the information and then make their presentations better. Yeah, I think we add, okay, it should be here. Yeah, give them this one. Oh, it's not working. It doesn't work. Okay. So yeah. So when you raise your hand, they'll bring you a mic. You ask your question, then they will let us know the person you are directing the question to.
Thank you. I don't know whether that's the second presentation. It's just a clarification on seroprevalence. That topic, please.
Seroprevalence of COVID-19 in Kumasi.
Yes, please. It's a clarification. I heard him mention immunoglobulin G. I don't know whether I heard him right. IgG. Yes, please. Am I referring to immunoglobulin G? Good. You indicated that the presence of IgG means that the person probably had COVID-19. The question I want to ask, or the clarification, is that this immunoglobulin is also present in certain conditions, like autoimmune disorders and other conditions. I don't know whether they've been able to rule out those conditions to just indicate indeed it is because of COVID that is high. Because the presence of IgG or its high level in the blood could mean different other conditions that I have mentioned, other than COVID-19.
Will you respond at once or? Okay. You ask another so that. Is it to the same person?
Yes, to the same person, but I have one for the last person too.
Okay.
Yes. This one, I just want to know, we're looking at the prevalence. We know they have done testing, and we have a percentage of positivity at that aspect too. And then you have also done serum. So I want to know the difference we have in Kumasi. Because you are saying that the serum will probably detect high number. So what is the difference between the serum positivity and that of the actual positivity that we did using the testing that we have done? I don't know whether you can help me with that. Is the question clear? Oh, okay. Then
the second person.
Second question goes to the last person.
The last presenter.
Yeah, the last presenter. With regards to qualitative, I think one of the problems with qualitative research is the issue with bias. but throughout the presentation, I've not heard anything relating to how you try to solve this bias. So can you please help me how you were able to take away that, subjectivity from the results? And I want to know too, which method with regard to data analysis did you use? I don't know whether you mentioned it. I want to know. Thank you.
Okay. So we will have the this way. Yeah, that will be the fourth question, and then you can respond.
Yeah, good afternoon. Thanks for your wonderful presentation. I don't know whether it's a question or a concern. You know, COVID-19, we are all trying to prevent it as much as possible. But one key method that we have to put in place to be able for us to be able to bring it, if not even complete prevention, to the barest minimum of what? The infection. We realize that education is key. Education is key. We realize that people are now just moving about. When you even get to Kumasi or in Accra, where the disease is proving to be the epicenters.
So please make it snappy.
Yes,
So that they
people are not even wearing the masks.
Capture the information.
So I don't know whether in the other side they have found that, and what are the measures put in place to encourage people to continue masking, because that's one key aspect of what? Prevention. Thank you.
So it's directed at the last. Okay. So you first.
Thank you. So one of the concerns, I'll start with the first one. How are we able to determine that the IgG responses we are seeing could not be due to other things, but could be because of COVID alone? There's a simple thing we do with the assay we used, which is an immunology tool called the enzyme-linked immunosorbent assay. We use a protein from the virus that causes COVID as the antigen at the bottom of the plate, and we add the sample. So the IgG that we are getting, or we are measuring, will be IgG that is bound to a protein from the virus. And this is how we are able to measure only IgG that binds to the SARS-CoV-2 virus. So it's an inherent method we used in the assay. So we know for sure that this is something that is produced in response to the SARS-CoV-2 infection, or the virus for that matter. There was a question on the difference between the positivity rates and the seroprevalence. We are currently working on a paper, a review paper, and what we did was that we took the reported cases of PCR confirmed cases, transposed them per 100,000 population, and compared to seroprevalence data from the respective places around the same period. And one of the things we saw was that for every one confirmed case, there were 5 seropositive cases. And so the opportunity, or the missed opportunity, was quite significant. And there's something that we know, that we've been able to determine. I'm not sure if this could be useful information for you or answers your question specifically. So we know we've not done that in Ghana alone. For Africa, we took the data from So that's about it. So we know that for one seroprevalence, for one confirmed case, there are about 5 seroprevalent cases. Perhaps I'll defer to John.
Thank you very much, Prof. And thanks for the question. Just to add a little bit to it, when it comes to the positivity rate and comparing this to the seroprevalence, it's a bit tricky in the sense that with your positivity rate, it is only what the number of positives out of those who are tested. Whereas in your seroprevalence, it's sort of a random sample and trying to see how many of them have the antibodies to the SARS. But the additional challenge in there is the period over which you are doing this, where the seropositivity is cumulative in nature, so you can look at all your tests and what proportion of those are positive. And because your testing in itself is a function of an index of suspicion, it would not actually be right to compare positivity rates to seroprevalence, because with seroprevalence, you sampled over a period of time. Now, the argument would be that if you sampled over a period of time to take serum and then see whether they had antibodies, it could be an inherent bias. But the argument is also that the antibodies would be there for a period of time. We now know that 4 to 6 months at least they will be there. And so you could argue that it's as good as doing a point seroprevalence, even though we did it over a period of time. So while we can argue that there is, at a high level, evidence that the seroprevalence was much higher than looked at, putting them side by side is not very helpful. You must look at the conclusion. The seroprevalence rate was much higher.
Thank you, Doc. Now, the second.
I think I'll try to remember one of the questions. You were talking about subjectivity with respect to qualitative research. And bias. Okay, so is this, okay, so with, I think the second one was about data analysis. Yeah, what the kind of analysis that I use. With that one, I mentioned in the presentation that I use thematic analysis. That is the one that has been propounded by Braun and Clark. And it's, you read the transcripts, then you code, and then you group those codes into subthemes. I don't know if you heard me. So you go through the transcript, then you start coding. And when you code, you group those codes into subthemes. And then as you read through again, you refine it and all of that. You then gather and put them, group them into themes. And those themes become what you present as your findings. So that's the data analysis method for what I did, thematic analysis. Yeah. And then when it comes to qualitative research and subjectivity, you really can't take out subjectivity from qualitative research because you are recording people's experiences. And so it is those individuals, their experiences or views or perceptions that you are putting across. So usually what we will do is, there are methods that you undertake to make sure that you are reporting credible information. And that is by, we have something we call peer review, something like a peer review. That if you look at the authors for this, there are 3 of us. So all 3 of us would read through the information, code it, and do the code, create the themes and sub-themes. And when we do, we compare with each other to make sure that we are reporting similar findings. So we independently do these and take these measures. And usually if you come together and then we find that, okay, so you have this code, you also have this theme, then that means that, we are agreeing on one thing. That means this is probably what the participant or respondent is trying to say. So this is one of the methods. There are there's also a way of going back to the participants and ensuring that you are reporting what they have said. So you go back to them, you tell them that this and this is what, after interviewing you, this is what and what I found. So I'm bringing it back to you. Is it right or wrong? If they agree, they will tell you. If not, they will tell you. So you are making. There are so many methods that we use that if I'd have to go into it, it will be a lot.
So, you asked for a lecture and you had it. Mm. But who asked the question, please? Yes. What element of bias did you notice in the presentation? Because the idea here
You see,
is to help her make the presentation better.
yes, I think what he's saying is right. The only challenge I have with it is the fact that it's making it look so theoretical. What did you do? So I was expecting him to say, her to say, I did peer review, okay? So that I will know that this is what they actually did, But it's like from the way he was talking, I was not seeing it being part of the work that they did. Then coming, let's come to the analysis.
Analytical aspect. Yeah.
Yes, the analysis. You see, if in qualitative, if you are going to use thematic analysis, I was expecting to have a model, and then that model will help you get your teams. So that is what I was expecting. I expected a model once you mentioned thematic analysis. If you didn't use model, I was expecting to hear content analysis. Where you don't have a model, you go by content analysis. So that is how it is done. So maybe I didn't know, so maybe you can look at it. If that is looking at the way it is, then you look at it again. Thank you.
I am part of I'm a co-author, so the issue about bias. In fact, one of the things we did, we brought, one of the participants was our client. And so we brought him back, and then what we had transcribed, the transcription that we had done, we showed it to him. Was this what you were talking about and all that? So there was something like that. And then we checked among ourselves as well.
All right. I think that is solved. So we'll go to the...
I think the last one was I don't know if it was the question about the education bit. I think throughout the three presentations, and I will start with the 40% seropositivity in Kumasi and the kind of emotional toil that the patients will go through at isolation, and even the health workers will go through. I think nothing drives home the message better than the COVID-19, aside its physical effects that you'd see from being positive, that at some point you did have COVID-19, even if you didn't know it. That fear alone should prompt people that you should continue to take the preventive measures seriously. So I do clearly agree with you that we should promote education on COVID-19. Even now that people are getting comfortable, the education should be more strengthened. Thank you.
I think that answers that. So, any more questions? Yes.
Thank you very much. Thank you so much for your insightful presentations. I just want to find out from Dr. Anochewa if they were able to find out from the patients at the isolation center whether the coronaphobia affected only them or it extended to their family members, and did that heighten their sense of anxiety? Thank you.
Just to follow up also a bit on the question that I think somebody asked about the IgG antibodies, how specific they are. I think I heard Dr. Mfum mentioning that because it's derived from the antigen of the virus, it is likely to be the one. But this is one of the challenges with serological kits. If you take, for instance, the spike or nucleocapsid, there are 7 strains of coronaviruses that are highly cross-reactive. So our previous studies, for instance, we have as much as 70% of people who have antibodies to 229E, HKU1, OC43, which we had before COVID even came in. So if you screen, with many of the assays and rapid kits available, you may want to step in and do either a plaque microneutralization assay that will enable you to specific zoom down to exactly what is due to COVID, SARS-CoV-2, and not maybe SARS-CoV-1 or not 229E. So I think that maybe the second level will be to pull the serums positives together and then use a microneutralization assay to enable you to now tell exactly whether what you are seeing is not HKU1 or 229E. Maybe that, I think, could be the. I'm sure they have it in plan, but this is what I'm thinking. Thanks.
But Doc, they use ELISA. In order to rule out anamnestic reactions, there's a cutoff below which they will consider it negative, and above will be positive.
Yes.
So, what we are raising,
the ELISA is coated with a part of the virus, which is the spike.
Yeah.
The spike is possessed by 6 other strains of coronaviruses.
Mm-hmm.
It's difficult to use the spike to differentiate among them unless you use another technique where you grow cell lines.
But this is only measuring exposure.
Yes, but you see, somebody is asking how specific, which is why I'm trying to build this up.
Dr. Ozu, I think I get you very much. I think that one of the strengths of our study was that the kit was developed de novo in response to the pandemic, and validation as well using sera from pre-COVID and also using flow cytometric analysis. Now, the thing, in using an antigen from the virus, you want to always choose a part that is conserved. So regardless of the strain the virus is from, that the antigen, once it binds to the antibody and the specificity is very high, you would expect that any of the strains will be captured by the assay. And the test is qualitative. We are now in development to develop the quantitative aspect of this. So if you have been exposed to the virus at some point and you have immune response, whichever IgG you produce will bind to the proteins given in the assay. And our test will not tell which strain you were infected with, but it will let us know that you were infected with a SARS-CoV-2. And this has been validated using, there's a paper that has been published on this I'm happy to share with you. So I think that we are saying the same thing, and what you was a disease of the affluent and the educated. And one of the interpretations we came with is that when educated people are sick, they go to the hospital. They allow themselves to be taken care of. And we are much more likely to capture data from a sick educated person than somebody who's uneducated, does not even believe they have COVID. And we do know that people had died from COVID even before we got to know that they had COVID. And prior to being at the hospital, they had been home for weeks. I think that most of us have been at places or even on social media where the campaign is that, you know, there's a propaganda and that COVID-19 does not exist and it's a 4G or 5G something. So the issue is not even just with literacy alone. It is with getting even educated people to believe that we do have a pandemic, that there's a virus on the loose, and we have to take caution. So I agree with you completely that, you know, and this is supported by the 40% seropositivity, that out of every 10 people, 4 of them have been infected at some point with the virus. And we saw this even so with a recent study we are doing where people were just being screened to be enrolled on the study, and you realize that coming up with people who are COVID naive is actually a much difficult task.
Thank you very much. Now it's your turn to respond to education and the mask wearing. But do you agree that we should educate, and how do we go about it? Will you stand in KGT and start talking?
Okay. Well, I do agree with what with the education, and also with education and ensuring that people wear their mask, to ensure that people wear their mask. And this is in response to what my two colleagues have said about the research that they have conducted, and what they found even among people who didn't have any idea that they had been infected with COVID, but then they found out from just giving their blood samples and being tested. They came to know that they had COVID, and this could be because maybe they weren't even very taking the various precautions that needed to be taken, and so they were probably just living their lives and may have come into contact with it. But I mean, I can't say it's much louder than what my colleagues have said, so I think I'll ride it on their wings. We can do that through the media. There's social media. There's proper education with professionals, and inviting them to the media to engage in having conferences like this to discuss COVID, to talk about it on the radio, TV. Yeah, it is. So I think it should be enhanced, basically. But there was a question for me on coronaphobia. Yes, and yes, the participants that we interacted with did have exhibited, even though they didn't say it, they exhibited some form of coronaphobia, because some of them were afraid, and they were afraid that when they found out that they had been diagnosed, they were afraid that if they interacted with their family members, they were also going to get coronavirus. So some of them opted to be taken to the isolation centers because of those perceptions that they had. And some of them even reported that their family, they were afraid of even telling their family members, because some of them, one respondent said, I'm afraid to tell my mom, because if I do tell her, she's going to die before even I would die. No, then he felt because he'd been diagnosed with corona, he was going to die. So those were some of the things that they were experiencing. They had families who they didn't want to know because they were afraid. Some of them had, one respondent said, my family member had BP, so if I tell her, BP is going to go up. Another one said she's going to fast 2 weeks, that I'm in the isolation center. So these things kind of heighten the anxiety for them.
All right. Thank you very much. Any more questions? Yeah, Doc.
I want to find out what accounts for the fact that your study says that the seroprevalence is about 40%. But if you compare to the number of clinical cases we're seeing, the number of deaths, it doesn't match. What is accounting for that?
The question goes to
prevalence to determine if the proportion of the population that at any point had infection, that may be hard, because
addition, there are many asymptomatic infections. They don't show disease, but they carry the organism and distribute to others. Yeah, more questions, please.
Thank you very much. My name is Akosia Samwa. My question is actually, well, it's not really a question, it's more of a comment towards the immunoglobulin question that was asked initially. I think that probably if the name of the specific antigen to which you developed the antibodies for, or to which you were searching for the particular antibodies, was mentioned earlier in your presentation, probably it would have helped. I believe Doc mentioned some of the antigens, the spike antigens and those things, and I think if that was mentioned in your presentation, it probably would have helped have other questions that came up with. So I don't know if you could help us with the name of the specific antigen to which you tested for the antibodies. That would be really great. And my next one is actually, we are also doing a study at University of Energy and Natural Resources, but we are using an immunofluorescent assay that detects percentage inhibition. But I want to ask, with the ELISA test that you did, was it a qualitative test or was it a quantitative test? If you can speak to that, and then how best we can also be trained on how to use this ELISA. If someone wants to be trained from outside your team, is it possible for us? Thank you.
I just want to make a quick comment. Tony will speak more to your question. I think the paper has been published on the method which was used to develop the assay. So we can share the link with you. It was validated using pre-COVID sera. So it's pretty robust. And this work was also done not only in Ghana, but also in a couple of other African countries. So Tony will speak more to that. But I think one thing he mentioned, which I thought is very interesting finding, I was expecting maybe a few more questions, was the education gradient that we found with the seropositivity, where those who have lower educational level had higher seropositivity than those of higher educational level, which is opposite to what the notion has been, that it's a disease of the more affluent. So the lower your educational level, the more likely you are to be seropositive, which is in line with what we know regarding risk of infection and disease. But this is not what manifests with regard to your positivity rate, because you would have, as he said, the richer, the more affluent, the more health conscious going to hospital. So this is a very important point that needs to be dissected further and also used in educational campaigns to really show that it's actually the poorer and the disadvantaged who are at higher risk instead of the rich.
Thank you. Yeah.
Yes, my question is to the second presenter. You spoke well about the ELISA antibody test that you have developed with your collaborators, and then I think you went on to tout it as one of the best. I want to know whether it is commercially available so that others can also have use of it in their labs. And then also, I think I heard that you said it takes, is it 24 hours before the test is completed? Why does it take so long, if I heard you right? Thank you.
So I'll start by answering the last question. And so it takes quite some time. The first, the coating antibodies, the use of the cluster of the CD molecules takes overnight. So you have to coat a day before and leave it a day overnight before you go through the rest of the assay. Because you are having to do using ELISA, some of the assays will take more hours because you have a lot of information and sometimes minimum of an hour, and you can have 5 to 6 or 7 copies depending on which assay you use. The BNI team, there's a group that developed this assay, and the interesting thing they did is that it's qualitative. This also answers the question the other gentleman asked. It's qualitative. The interesting thing is that it was developed using different cutoffs for different regions. And so for the assays or the kit that was sent to Ghana, it is because you are taking samples from Ghana and use that to develop the cutoff. This is a problem with some of the assays that are available on the market. Perhaps that could lead to higher seroprevalence using some of these assays. it's one of the top